Hello, everyone, and welcome to the Maternal Mental Health Report podcast, where we empower providers with the tools, insights, and advocacy to transform maternal mental health care. I'm Jessica, and today's episode is an exciting one. I'm super excited to hear from my good friend Elise.
Hi, everyone. My name is Elyse Springer. I'm a marriage and family therapist. I'm based in Los Angeles, and I'm licensed in California, Oregon, and Washington. I actually got my start in perinatal mental health, like many clinicians in this space, because of my own personal experience. About 15 years ago, I was already a licensed therapist, and I had my first. I had an emergency C-section and I coded after. And of course, that was a lot. And I had no idea what was going on, right? I was tearful every day. I was really struggling. And I went to my gyne at my appointment, my first appointment following the birth of my kiddo. And I said to my OB, I'm crying every day. Is that normal? And my OB's response 15 years ago was, that's just new motherhood. And I went to my therapist because, as you all know, or I hope most therapists are in therapy, right? We're trying to destigmatize this. So I'm pretty open here. And I said to my therapist, I'm crying every day. Is that normal? And my therapist said, well, your family of origin. So here's the thing, though. I had no idea. And it wasn't just because it was new motherhood. It wasn't just because of my family of origin. I had a perinatal mental health issue and concern. Typically for me, I had postpartum PTSD. And I did not know that until I happened to, because I might be a little bit overachieving. And especially with my first leave, my first, maternity leave, I was in a CEU on EMDR, right? So I'm a certified EMDR consultant and practitioner. And I was at the time was doing some CEUs in EMDR. And I remember having a moment where I was like, is postpartum PTSD like a thing? That was literally the thought that crossed my mind. And so I thought, well, I guess I should look that up. And I went to my university's library and was like looking for all of this research. And there wasn't a lot because there really wasn't online much at the time, right? Postpartum Support International was much smaller. And, there were a couple of books out, most notably Dr. Diana Barnes, who I consider a mentor. She had put something out and I happened to stumble across actually one of her articles and a couple of others. And I brought them to my therapist and I said, hey, like with all due respect, I think something more is happening here. And it was a really interesting conversation for the two of us to realize that there was absolutely no training in perinatal mental health, right? And at the time, I happened to subsequently get an email from a colleague who had just started at something called the Los Angeles Perinatal Mental Health Task Force. And from there, I did get hooked up with a couple of my really wonderful training mentors, Dr. Diana Barnes, as I mentioned, and Gabrielle Kaufman, who was the training director at LA County Perinatal Mental Health Task Force, which turned into Maternal Mental Health now. And, I did a lot of training with them, and that really fueled my passion because it was just a total mind scramble to understand that I was a licensed clinician. And at the time I was working with very complex population. I was working with folks who were unhoused and HIV positive and generally had addiction. Primarily meth was the drug that I was sort of working in that population. So I was working with really complex population and just blowing my mind that how could I have gotten through grad school and gotten this position and been doing the work I was doing without any training or knowledge that this was a thing? And more so, how did my own therapist, who had been in practice for 30 years, not know it was a thing? And then even more so, I had literally asked both my OB and my therapist. And I think one of the things when I talk about this is I have to acknowledge my privilege, right? I'm cis presenting and I am white. And I had the education behind me to ask for help. And, I think that was a big fuel for me because to start to change my career and focus on perinatal mental health, because what I realized was, well, if here I am with all the privilege in the world, had this experience, there are a lot of other folks who don't have that capacity or don't even know what to ask. And so that was a real factor in my journey towards shifting my practice, and really focusing and doing a lot of the policy and advocacy work I do now. I mean, I know, again, Jessica, we've only known each other for a little bit, but my passion usually comes across pretty loud and clear. I can be a bit bullish about the need for training here. And it's exactly for this reason that sometimes when I have a new client, like I just had this past week, who has, fallen through the cracks and nobody recognized what was clearly a perinatal mental health concern, it digs at me a little bit that 15 years later, we're still in this kind of same position where folks are falling through the cracks. Now, of course, we've come such a long way. There's a lot of information online now, and a lot of the great organizations like PSI and Maternal Mental Health Now, and a lot of the other organizations, including Policy Center for Maternal Mental Health Now, have done some real important advocacy work, but we are still here and we still have quite a bit to do.
So it's really important, and to your point, 15 years later, right, we're still seeing the same kind of thing, and it just breaks my heart every time I have to have this conversation. But I can say that I've started to see where there's been a shift in the conversation and more conversation around it and awareness. And they were having that conversation, and it was like, yes, finally, at least there's some awareness around it now, where even in television and in media, there wasn't any conversations. You'd see mom have a baby on TV and it was just kind of like, oh yeah, they step back and back at it again, right? There wasn't any coverage of it at all.
Well, a lot of the myths of motherhood, you pop out a baby and then you're standing outside the hospital,
Right.
if you're a celebrity looking beatific, right? And I think that even as recently as Kate Middleton, I think that was a pretty good example of the expectation of you pop out the baby and then you're press ready in 5 minutes. And we just know that that's not the reality, right? We know now that there's some mandatory screening, and in 2019, AB 2193 in California, did a lot to support that at the very least people get screened. So they don't necessarily have to have the understanding that they need to go in and say, is this normal?
Right.
Right. And I think,
or is something wrong with me?
is
Right?
something wrong with me? Or is there something I need extra support on? So at least that has happened. But I think what has really lagged behind, and you probably knew I was going to go here, is that we still, for all of our screening mandates that we now have in place in California, which is not true necessarily in the rest of the country, but we still do not have an educated workforce. So we still do not have at a master's level for anyone who's a social worker or a licensed professional counselor or licensed marriage and family therapist. We do not have any mandated training, no continuing education units, no education units mandated for licensure, so that people even know how to recognize maybe what they don't necessarily know in a client that's presenting or in a patient that's presenting, and how to refer them out, right? So we are continuing to do a big push towards screening, which is important. And we're continuing to do a big push towards doula support, which is incredibly important. And the same thing with peer support. However, all of those legs of the stool are missing one important component, and that is direct service treatment, right? And a lot of times we can't have a workforce that's educated when training isn't required. So speaking of HIV and AIDS, one of the things that happened back in 2002, when it became apparent that there was a real need for clinical awareness, there was a mandate that the licensing boards did require about 7 hours of training in HIV and AIDS. And so, we have a pretty small population in the state of California that are HIV positive. It's still an issue and it's still important, right? None of this is to say that we want to take away that kind of training. But I think what people forget is that we have 400,000 births per year. It's actually a little bit more. Like I think it was 419,000 in the last couple of years. So that's 800,000 new parents per year in the state of California. And yet, there is no training mandated for all of our therapists. Here's what that means is, though, when you have someone who has an issue and maybe they do get referred to a clinician, the clinician may not understand what they're looking at as being a perinatal mental health concern, right? You might have a hospital social worker who gets a screen, but they may not have the training to understand and be able to differentiate between what is postpartum OCD, postpartum bipolar disorder, or postpartum psychosis. And I think that it's not even a question of are people going to specialize in perinatal mental health, but we need to have baseline training. I mean, in an ideal world, it's they're going to be sent to a perinatally mental health trained therapist who can do a full assessment and assign a diagnosis and then refer to a equally qualified perinatally trained mental health clinician. That's really and honestly, the system isn't that hard because it works in other arenas. It works in HIV AIDS, it works in substance abuse and dependence. That's what the model is. You get a full assessment, you get a diagnosis, and then you get referred appropriately to someone who's appropriately trained. It's always so interesting too, because with the managed healthcare plans, a lot of times people are like, it's too expensive to either have people in therapy or to train therapists. And I think this is one of the reasons why I always look at this, look, as a therapist, I have to pay for my own CEUs. Nobody, in order to be a licensed therapist, if I'm working at a county clinic that's an FQHC, that's federally qualified healthcare, provider, I have to maintain my license by getting continuing education units. That is a burden that is a part of my profession that I have to take on for myself. So, when we're looking at like the cost here, this is where it's like, if you look at it as an upstream approach, if our licensing boards mandated that we had this training like they do for, I don't even know, human sexuality, which is another one that they mandate, or again, like drug and alcohol or HIV AIDS, like it would be my responsibility to do a one-time training to get a basic training, CE. And what that would cost the managed healthcare plans? What would that cost them? $0 because it's part of maintaining a license. So, when we're talking about the burden and to all the therapists who are like, I don't want to have to pay for one more thing. It's like, you got to pay for it every 3 or 2 years anyway, right? Like you have to stay in compliance with your license. You have X amount of continuing education you have to get. It should be perinatal mental health. That should be a one-time requirement for everybody. And you have to pay for it anyway. And then it doesn't cost the state anything and it doesn't cost the insurers anything. So to me, it's like, what is the most cost-effective way to do this? Let's make this a basic requirement. And then you're going to catch those providers who say, hey, this is really interesting. I think I'm going to specialize in this. I think the PMHC is really the sort of nationwide sort of barometer here right now. I know I'm bringing substance use and dependence as a model here. But again, I mentioned that CADAC, that's that certified alcohol and drug counselor designation. And the perinatal mental health certification is the PMHC, and that's overseen by Postpartum Support International, which is a national nonprofit. And, usually in order to be eligible to sit for the exam, you have to have several, days of training and, experience post-license. And what's cool about the PMHC is that they have, it's not just for clinicians. Doulas can be a PMHC, so they can be experts in their particular lane. The same thing for frontline providers. So that to me is like, if you want to specialize, PSI, Postpartum Support International right now is the nationwide leader for training with their PMHC designation. And that's at least lets others know that you've gone through at least a rigorous training. And there's lots of other organizations where you can get some of those prerequisites for PMHC. And, there's a lot of, and forgive the word, but sister orgs that PSI works with that do provide some of those trainings and those basic trainings. And also, similar to your license, in order to maintain your PMHC, that perinatal mental health certification, you have to do some CEUs. So a lot of local orgs also provide those continuing education units in perinatal mental health too. It in essence requires the healing arts boards to consider requiring training in perinatal mental health. And
Mm.
as of right now, March of 2025, unfortunately, several of those healing arts boards, including the physician arts boards and the boards of registered nursing, has said, no, thank you. We've considered it, but we're not going to require it, which is pretty disappointing when you think about ways in which a basic ability to recognize a perinatal mental health concern would really help for both of those particular disciplines. But we have not yet had what it seems like are full hearings at either the Board of Psychology and the Board of Behavioral Sciences. So I've gone to a lot of the Board of Behavioral Sciences meetings, and I've been focusing on them a lot because if we think about our systems of care, Board of Behavioral Sciences oversee a lot of all the LCSWs. That's who the designation is
Okay.
for LCSWs. And we know that
Mhm.
a lot of social workers work in, for example, DCFS, Department of Children and Family Services. And we know that there's pretty frequently not enough training of those providers in DCFS or Child Protective Services. They just don't have perinatal mental health training. And
Mhm.
so the focus has really been on, look, here's the thing. Grad schools really determine their curriculum based on licensing requirements. So even if, let's say, an Masters of Social Work student goes through grad school, they can have zero training on perinatal mental health. They actually may not even get licensed because you do not have to be a licensed social worker to work at either Child Protective Services or GCFS, let's say. And they are really missing, I think, a lot of the components that might be a factor in what is happening in a household. They're going to not have the knowledge and understanding, hey, this is a mom who could really benefit for treatment, that substance use is a secondary characteristic of this perinatal mental health concern, and we need to focus on what is really happening here, which is the perinatal mental health concern. So that's a good example, but if you have clinicians who have just gone through grad school and aren't licensed, but in neither place
Yeah.
maybe it is a licensed social worker who's working at DCFS, but if they've never had this training, they may not be looking at it because they're not looking at, okay, now you've got a mom who's had 3 prior losses
Mhm.
and now she's struggling with some postpartum depression or anxiety, and she's self-medicating with a substance. Instead, they're not looking at this as a family systems issue.
Yep.
So to me, why I'm focused so much on the BBS is because that is really happening. And what we know is for our folks who are really at that juncture of intersectionality. So maybe it's someone who's a person of color and is struggling with both systemic racism and those other components that really make up intersectional concern. But this is a real issue. We know in California, people of color struggle at higher rates than white counterparts, and a lot of times there's higher level of involvement because there is not just that systemic racism, but within that system, there's a lack of understanding of how something like that combination of adverse childhood experiences, intersectionality, and perinatal mental health are all combining to create a system and a situation that they're, trying to involve themselves in. Well, I really was grateful to read the Birth and Care Pathways report. One of the things that I found so interesting is that there really wasn't an understanding, seemingly, in anything I read, that the reason why there's a workforce issue is because there's no training. And it made me wonder, I just really genuinely think I am always surprised when I
Mhm.
come across either MDs or surgeons or folks who are working in policy or insurance who don't know that there is no basic training in perinatal mental health in any of these licensed designations. And
Mhm.
so to me, reading that report, I thought to myself, oh my gosh, this is amazing. I really appreciate that they're saying, hey, we need to improve workforce access. But I'm just thinking, do you even know that your workforce doesn't get this training at all?
Training.
Like you could throw warm bodies at this, but they don't have any basic knowledge because it's not mandated. So that to me is like
Yeah.
really when I'm looking at that sort of the pieces of the birth and care pathways, I was appreciative to see that they were able in moments to recognize, hey, we need increase in workforce, but it seemed to me that it was really missing that your workforce is not mandated in any way to have even the bare minimum of understanding around perinatal mental health concerns. And one thing that has just been fascinating to see exactly is like, how is it that we're so focused on human sexuality and we're so focused on children, but parents are left completely, right?
Yeah.
And so not just moms, right? And dads too, which is my other soapbox that I'll wrap up with. But I was just having a conversation with a colleague today about, dads who die by suicide in the perinatal period, right? Because we know for dads, onset for their paternal perinatal mental health is usually between 3 and 6 months. And, for example, if there's a 35-year-old male who dies when his child is 6 months, we don't even sort of have a category to track that it's a father because we don't pay attention at all to the impact that having children has on fathers. And what we know is that, look, there's a real sort of down the line impact on children when dads have depression or OCD or anxiety. And there is some interesting questions to be asked about, well, if the onset of intimate partner violence or domestic violence is during pregnancy, primarily around third trimester, and we know in third trimester the dad's testosterone is dropping and estrogen is rising in preparation for bonding of the baby. Is there some correlation there? And we just don't know. We have that stat around 1 in 10 dads suffer, but that stat is like this is like from 2005. I don't even know when the last time that study was validated. So we have no idea what the real truth is. And so again, much in the same way that we've siloed things for mothers and babies and not necessarily paid attention to it, we've really marginalized dads in a
Right.
whole other way. And if I understand. I know a lot of folks are like, well, can't women just have one thing? That is always what I get when I bring up dads. But I'm really looking at this of like, yes, but if we really want to break any intergenerational cycles, we need to be looking at the family as a whole.
At the whole unit. Love it.